Okay, I think we'll start as it's 6:31. So good evening, everyone, and welcome to the inaugural SHARP educational webinar series. My name is Jacob George. I'm the current chairman of SHARP. I'm also a professor of cardiovascular medicine and therapeutics at the University of Dundee Medical School, and I'm lead for the cardiovascular risk service at NHS Tayside. Firstly, can I thank you for registering for this webinar? We hope to run these webinars every 2 to 3 months with topics such as management of hypertension as today, diabetes, dyslipidemia, stroke, peripheral vascular disease, things that are hopefully relevant to you in your clinical practice. And this is aimed to be as broad as possible for it to be relevant to primary care, secondary care, medics of all grades, medical students, nurses, allied health professionals, anyone really who's got an interest in the care of cardiovascular conditions. But before I go any further, can I just make a pitch for SHARP as well? If you haven't already, please consider joining SHARP. We waived the membership fees, so it's completely free. It is a great forum to connect with other professionals who are involved in the care of patients with cardiovascular disease who have an interest in management of cardiovascular conditions. You have access to our webinars. You have information about educational series. You're welcome to attend the annual scientific meeting. And above all, I think, like I said earlier, it's a great forum for networking and connecting with others similarly minded within Scotland. Number of sort of housekeeping rules. First, the lecture today will run for about 40-45 minutes, and we'll have about 15 to 20 minutes of Q&As at the end. So if you'd like to ask a question, you could either type it in the chat or preferably raise your hand and turn on your video and ask the question at the end. All participants are currently muted, but you'll be unmuted during the Q&A session to enable you to ask those questions. And we will email you a certificate of attendance, which hopefully will be useful to you for your CPD and your appraisal and all of that. So we kick off this inaugural lecture today with Professor Tom Macdonald. Tom does not need an introduction to most of us, but if you're new to SHARP, Tom is Professor of Clinical Pharmacology and Pharmacoepidemiology at the University of Dundee. He's also Director of the Medicines Monitoring Unit, or MEMO. He is past president of the International Society of Pharmacoepidemiology, or ISPE, and the British and Irish Hypertension Society. He is an internationally recognized expert in hypertension. He has published extensively on hypertension and cardiovascular diseases over many years. And I think he has also been chief investigator for a number of large multinational studies such as FAST and TIME. So it really is an honor to welcome Professor Macdonald to give us the inaugural lecture for this webinar series on the management of hypertension in the community and some tips on when to refer. So hope that will be useful to all of you, and over to you, Tom.
Thank you very much, Jacob. I'm going to try and share my presentation now. Here we go. Presenter mode, that's what I want. Hypertension. Does anybody see this? Ah, there we go. From the beginning. Right, can you all hear me?
Yes, we can. Thanks.
Excellent. Well, thank you for inviting me to give this this lecture. This was the title I was given, and in my first slide is what I was told when I was a medical student, that hypertension is the level of blood pressure where treatment does more good than harm. Now, when I was a baby doctor, 160 over 100 was borderline hypertension or mild hypertension. So things have moved on quite a lot from there. And I think nowadays, and I think in the future, we will be treating much lower pressures, but I'll come to that perhaps. Now, who's this handsome chap here? This is me when I was a bit younger, wearing an ambulatory blood pressure monitor. Now, we did lots of work on these devices earlier in my career, but NICE eventually said that all new hypertension must be diagnosed using ambulatory monitoring. And then at the bottom they said, or home blood pressure monitoring. Now, some parts of Scotland have great regional-wide ambulatory monitoring services. We don't actually have that here in Dundee or Tayside, but we will do an ABPM for you if you want. A lot of GPs have their own ABPMs. But really the mainstay of all of these diagnosis and management of hypertension nowadays is home blood pressure, and there's lots of these monitors available. Could I urge you to go to the British and Irish Society, Hypertension Society, that has a list of all the monitors for home use that have actually been validated. And don't get your patients to buy a posh one, just get a basic model of, there's no point in spending hundreds of pounds, 30 quid or 25 pounds on eBay or Amazon is all you need to spend. Now, actually my colleague Isla, this is Isla, I don't really quite see Isla there, that's Isla Mackenzie. The Rotary Club of Dundee and the Gildery give our service via her £10,000 worth of home blood pressure monitors. Personally, I think we should be able to prescribe these monitors, but we can't yet. But the monitors that we bought have been extremely useful. We've given them to patients who perhaps find it difficult to afford these sorts of things. And it's not just ourselves, but the stroke service has also been given free monitors to give out. So if anybody knows of a Rotary Club or anybody who wants to give money away, this is a really good way of spending money. We know that people who own blood pressure monitors have better blood pressure control. So what do we do with home monitoring? Our advice is to ask patients to take 3 readings in the morning and 3 readings in the evening for a week. And you should consider perhaps ignoring the first day if it's wildly different from the others. But this gives you a good view of the average blood pressure that the patient has. And it really provides much the same data as the daytime readings of an ambulatory blood pressure monitor. Now, the reason that NICE suggested ABPM or home monitoring is this thing, the white coat effect. Because they reckoned that about 20% or more of patients would have a big white coat effect or alerting response, but they would have normal pressure at home. And they reckoned that, well, if you don't treat people for 5 years, because they reckon you should have another monitor after 5 years, that would be a saving. So we should all have an ambulatory monitor, but it's a bit difficult to do ambulatory monitoring in everyone. And then once you've done it once, do you do it again or you switch to home monitoring? So the white coat effects been the principal reason for their advice. But notice that there's this other thing here, which I'll come back to later, which is the dip in blood pressure when you're asleep. This is a study we did ages ago. This is 48 hours ambulatory blood pressure monitoring. And it's never cited this paper, of course. But anyway, this is the white coat effect you can see here. This is the first day of use, and this is the second day of use. So that's quite clear that first 2 or 3 hours after you put the monitor on is when that alerting response occurs. Nobody's quite sure the reason for the alerting response. It's actually interesting. There's a big spread of variation between patients. Some people have almost none and some people have a lot. And actually the cameo of the person most likely to have a white coat effect is an older female smoker with high clinic systolic blood pressure and variable daytime readings. So the older you get, the more common the white coat effect is, especially if you're a female smoker. Now, if you look at this diagram here, true normotension is when you've got normal blood pressure in the clinic and normal blood pressure on an ambulatory monitor. Sustained hypertension is when you've got both up. The white coat effect is when the clinic pressure is up, but the ambulatory pressure is down. And then there's this thing here. This is masked hypertension. We're probably not going to find it easily. Unless you have your own home blood pressure monitor, you're not going to find people who have a high ambulatory pressure and a normal clinic pressure. Because when we measure pressure in the clinic and it's normal, we don't bother measuring it again. But masked hypertension, I think, is going to be a problem in the future. Now, depending on what levels we choose for our normal ambulatory pressure and normal blood pressure, masked hypertension is about 10 to 20% of the people who've had ambulatory monitoring. So this is a significant issue. And when you look at the outcomes that you'd expect, white coat hypertension is this one here, white coat hypertension. This is normotension. White coat hypertension, not completely without risk, as you can see. This is masked hypertension, and this is hypertension, and this is the incidence of cardiovascular events. So hypertension is clearly bad for you. Normotension is clearly good for you. Masked hypertension doesn't appear too good for you, and white coat hypertension is not completely without risk. And in fact, the white coats often develop hypertension. It's often presages the development of sustained hypertension. So, yeah, the white coat hypertension is at lower risk, and probably you can delay treating them until they develop hypertension. So there are other advantages of AVPM. It determines this thing called the nocturnal dip. Now, the nocturnal dip, how much you drop your blood pressure when you're asleep, is a pretty strong predictor of outcome. And we find non-dipping in groups of patients like diabetes, where the autonomic nerves don't work too well, and certain forms of secondary hypertension. So non-dipping raises the question, should we give blood pressure medication in the evening? Because then you drop the blood pressure at night and reduce the pressure and therefore presumably the risk. If you have a bit of a rest from your high blood pressure overnight, it seems to confer reduced risk. People who have big dips at night seem to have a better outcome than people who have no dips at all. So this, I think it's been mentioned by Jacob, has led us to the TIME study. Now, the TIME study is funded by the British Heart Foundation, and it stands for treatment in the morning or the evening. And TIME has randomized in the UK over 21,000 patients with treated hypertension, randomized to taking treatment in the morning or the evening. And the follow-up is by record linkage and by self-reported cardiovascular events. And it's got, interestingly, quite a fully remote study. And if you want to read about it, I actually published the protocol in 2016. I mean, these studies just take forever to do. We actually are finalizing the study now. We hope to lock the database in May and present the results at the European Society of Cardiology in August. A lot of people are waiting for this because there's a couple of studies from Spain that suggested enormous benefit of taking tablets at night. And the International Society of Hypertension has just written a position paper on this. I contributed to it. And there's a bit of disquiet amongst clinicians that these results can't be right. You can't reduce cardiovascular disease by 50% or more by taking your tablets at night. So currently, we don't advise when you should take your tablets because we just don't know. Hopefully, the TIME study will clarify this. Now, this is an interesting conundrum because if you're all doing office, ambulatory, and home blood pressure monitorings, what do your results mean? And this is the European Society of Cardiology, European Society of Hypertension synthesis of the data. And there's lots of studies looking at clinic pressure and ambulatory pressure and home pressure and trying to map together the various, what they all mean. Remember that most of our outcome data comes from office blood pressure. That's, we know if you have strokes or heart attacks from office blood pressure, and we know how much you reduce that by reducing that. There's not these big studies with ambulatory or home blood pressure monitoring yet. So this is what they suggest. If your office blood pressure is 140 systolic, that would map to an ambulatory pressure during the day of 135. And that would be the same for home blood pressure monitoring, 135. And for your diastolic, 90 in the office would equal to 85 in the daytime ambulatory or 85 in the home blood pressure. The asleep blood pressure, there's a 20/20 difference on the ambulatory monitoring. And in the 24-hour mean, it's 10/10. Isn't that confusing to you? What it means is you've got to be clear what you're talking about when you're talking about ambulatory monitoring or home blood pressure monitoring. And we tend to talk about the daytime means in ambulatory monitoring. So these data were put together using the same database as the next slide I will show you. And the next slide is the American mapping of these data, which is a little bit different. So let's take the 140/90 to the side here to start with the clinic pressure. Yeah, they think home blood pressure 135/80, daytime ambulatory pressure 135/80, that's the same, okay? But if your pressure is lower than that, they say clinic pressure is equal to home pressure equal to daytime ambulatory pressure. But if your pressure is much higher, like 160/100, that's home blood pressure of 145/90, and daytime ambulatory of 145/90. So the higher the pressure, the bigger the difference between clinic and home or ambulatory pressure. So you've got to be somewhat circumspect when you're looking at home blood pressure. If you see a home blood pressure or daytime average mean blood pressure and ambulatory monitoring of 145/90, you think, well, that's not too bad, but it's probably 160/100. And this is not widely appreciated by even the high blood pressure doctors, I have to say. What I tend to do, and you could argue about this, when you look at the raw data, there are sometimes huge differences in some studies, between clinic pressures and ambulatory pressures. What I do is make up my own mind as to what to do. And the data, this is what I was saying, the data are the same, but the interpretation is different. I use 10/5 to correct daytime ABPM or mean home blood pressure to an office blood pressure. And you could argue that's more than NICE suggests. They say 5/5 or 7/5 or whatever. But we tend to see people with higher, more severe hypertension. So you could argue that with higher pressure, there should be a bigger correction. But it's not the same as the pressure measured in the clinic. So we're looking for 130/80 or 130/75 on the daytime mean to be below that to be normotensive. The next question I want to talk about is how low are you going to go with your blood pressure? I mean, some people might balk at this, 107/67, or even lower. How low should we go? As far as I'm aware, the only country that treats low blood pressure is Germany. And I'm not sure what basis they do that on. But is this a good blood pressure to have or not? Well, I would like to persuade you perhaps that it is a good blood pressure to have, as long as you're not falling over with dizziness and fainting. So this is based on two large trials. One of them was published in 2015, the SPRINT trial, where they compared a systolic target of 140 with 120. And this trial had to stop early, although it didn't achieve the 140 over 120, it achieved about 15 millimeters difference. But the 15 millimeters resulted in a huge difference in outcome. There's a slight nuance to this in that they measured blood pressure in a funny way. I think it's probably irrelevant, to be honest. But they put people in an office with a home blood pressure machine. So was it a home pressure or an office pressure that was measured? But laying that aside, the results of this were very dramatic. There was a 27% lower death rate and a 25% composite endpoint reduction in the whole trial. And people went, "Oh, that's amazing." But the elderly, you couldn't do that with the elderly. Oh no, they'd fall over. Well, they did. They did do a sub-study of the elderly, which I'll show you in a second. This was the benefits of SPRINT in the Kaplan-Meier plot. And the benefits started to appear after a year. And there was as you can see, a huge reduction in events with intensive treatment. Now, the elderly, they did a separate analysis of patients over 75. And they got even more benefit. 34% reduction in the primary endpoint, 33% reduction in mortality, a third fewer deaths for a 15 millimeter lower blood pressure. And really, there wasn't an increase in serious adverse events. There was a bit more dizziness, 2.4 versus 1.4% dizziness, a 1% difference in so-called hypotension, which I think you'd regard as being acceptable, wouldn't you? So the bang for your buck, in the overall trial, you got 1.91 reduction in events per millimeter, but in the elderly, you got 3% reduction in events per millimeter. So actually, we should strive harder in the elderly rather than the younger ones. Now, okay, this might just the one trial, but there's another trial that came along. Will you believe this? This is just in August last year in the New England Journal. That was 110 versus 130, they said. But they also said that, well, they try and get everybody below 130 and below 150. And in fact, they actually achieved only a 9 millimeter reduction. They got down to 126.7 and 135.9. It's about 9 millimeters difference. This was in Han Chinese. It was in a whole lot of different cultures, but in Han Chinese predominantly. They had to stop the trial early because of a benefit, an early benefit, and their benefit started very early and got bigger and bigger and bigger and bigger. So it's very compelling, isn't it? The lower the blood pressure, the better. And when you look at their forest plot, it was the elderly patients who got a better outcome, and the ones with the lowest blood pressure to start with got the best outcome. Very counterintuitive, I put to you, very counterintuitive. But these are the data. So the big thing that people used to talk about when I was younger was that there was a J-shaped curve, and if you put your diastolic too low, that was bad, it was very bad. But in this trial, they looked particularly for this, and they found no evidence of a really low diastolic or a really high pulse pressure. So I think we can say that very low diastolics are not necessarily bad for you at all. What is the best target blood pressure? Does anybody know? I think the answer is that who knows? And maybe it's 100, maybe it's below that. Of course, it can't be 0, but maybe it's the lowest blood pressure you can tolerate. I mean, you've all seen heart failure patients with systolics of 80 who seem to be asymptomatic, and I think we need to be more relaxed about lowering blood pressure in any patient, but especially in the elderly. And unless they're falling over, unless they're getting lots of dizziness, I would not back off their treatment personally. I know others do, but I don't think the evidence is there to do that. So probably less than 120 is the answer. That's probably the best target. And my mantra is you either have a bit of dizziness or you die. Dizzy or die. What do you want to do? I think being a bit dizzy is not a bad trade-off against dying. I tease the students with this study. There's 30,000 odd people in the All-Hat study, and it was one of the biggest studies ever done. And it compared ACE inhibitors and thiazides and calcium blockers and said, which is the best drug then? Which was the best drug? And they all say, ACE inhibitors. In fact, they were all identical. Now, the primary endpoint of this was coronary disease. So let's point that out for a start. And there was some differences with stroke and heart failure and things like that. But the reason I'm showing you this is that All-Hat and a lot of other big studies from America used clortalidone. And clortalidone is a great diuretic. It's probably the best diuretic. It's long-acting and it's very potent. It causes a few little problems now and again with hyponatremia and hypokalemia, but I think the good outcomes that they get in their trials is by using clortalidone. And I think it probably doesn't matter in the long run which drugs you use to lower blood pressure, but clortalidone is pretty good at lowering blood pressure. So the main benefits appear to be just due to lowering blood pressure, and you can do it anyway. In fact, you can probably give any drug. As long as it lowers blood pressure, you get the benefit. There's some nuances about that, which we're not going to hear, but basically the main benefits are due to blood pressure lowering, Treatment with any commonly used regime reduces the risk of total major cardiovascular events. So even combinations of drugs and things that don't appear to be the ones that everyone else uses are probably just as good in the long run. So NICE, after they looked at all of this, came to the conclusion that they couldn't quite understand that if you treat hypertension, it's a lot cheaper than doing nothing. So the cost per quality was, well, I mean, it was zero cost per quality, because if you treat it, you have really good outcomes. And so they recommended lots of things and how we should lower blood pressure, and these are what GPs and secondary care doctors do. I know that all these drugs are generic. I think that we're not spending much on any of these drugs. I think the case for lowering blood pressure in everyone is really strong. And the question is how to do that. Now, everybody follows this basic scheme of A to the younger people and C or D to the older people. This is based on renin status. Younger people tend to have high renin hypertension. And around about 55, 60, it changes to low renin hypertension. So A drugs block the renin-angiotensin system, C and D drugs stimulate the renin-angiotensin system. They've got a little asterisk against A, because we don't give A to fertile women unless they're absolutely certain that they never want to get pregnant. Because ACE inhibitors and ARBs are mildly teratogenic. So the second step is A plus C or A plus D, and then there's A plus C plus D, and then you can try something else, and then it says consider seeking specialist advice. So the first tip is that once you run out of treatment options, you can refer them to us, because that's what NICE says. And the further diuretic therapy or alpha blocker, or if they've got another indication, probably a beta blocker. C or D drugs in over 55. The Europeans tend to favour C, the calcium channel blockers, because a lot of the trials suggest that C is pretty good. And the USA tend to favour D, the diuretic. And the reason for that is that clothalidone is such an effective diuretic. And this is the mapping of diuretics, the dose required to reduce systolic blood pressure 10 millimeters. And you can see that clothalidone needs a teeny weeny dose to lower the blood pressure 10 millimeters, and hydrochlorothiazide needs more than a usual dose to lower it 10 millimeters. Benzoflumethiazide doesn't do too badly. Now, clothalidone is currently £88 a month, I think, in Britain, so we tend not to use it. But we don't use it, can't even, well, you try prescribing it. So we've basically, NICE said we should choose between benzoflumethiazide or indapamide. Now, benzoflumethiazide is a thiazide, indapamide is thiazide-like. Clothalidone is actually thiazide-like. We've actually been doing this study called the evidence study, and many family doctor practices might be taking part in this, because we've randomized, I think, about 82 practices, and we randomized the practice to change their practice prescribing policy. So they change everyone in the practice on diuretics, either to benzoflumethiazide or to indapamide. And then we follow them up long-term using record linkage. So that's 16,000, 17,000 patients randomized. And we're hoping to increase the numbers to over 100 and then wait and see what the outcomes are. And although it's a cluster randomized trial, we think there won't be much cross-pollution here. And I think this might, if these drugs are the same, we'll use the cheaper one. And if these drugs are, one's better than the other, or one's worse than the other, we'll choose the better one. There's a multidisciplinary team doing this, but I thought I'd show you Amy Rogers here, who's one of the team. She's a GP who's been working on this along with many others to try and deliver this project. And we have pharmacists and others doing it. Now, of course, everybody targets treatment. We give beta blockers or calcium channel blockers in angina. We do give beta blockers to fertile women because ACE inhibitors and ARBs are probably not the right thing to do. In heart failure, we use ACE inhibitors, diuretics, beta blockers, spironolactone. Diabetic nephropathy, we use ACE inhibitors, ARBs, alpha blockers in prostatism, diuretics in the elderly. Diuretics in the elderly because it prevents osteoporosis. I don't know if you knew that, but the reduce calcium in the urine. We tend not to use beta blockers unless there's a good indication other than hypertension, arrhythmias, coronary disease, heart failure, or this thing called increased sympathetic activity, whatever that is. But if they do need a beta blocker, cotenedone contains chlortalidone. So you get the chlortalidone for nothing. Bizarre, but that's quite a good tip. There's a half dose drug and a full dose drug. So cotenedone, if you're stuck, you're on a beta blocker, you need a good diuretic to lower the blood pressure a bit more. Now, combining drugs is actually a lot more effective than adding drugs. It's about 5 times more effective. And usually, we instead of increasing the dose up to, and I'll show you a slide of this later, increasing the dose to where you get side effects, we just add another drug. And one of the things that hasn't really caught on, but perhaps should, is that we should start people with reasonably good going hypertension on 2 drugs to start with. So this was a study we published in The Lancet some years ago now, and the blue line is aliskiren and amlodipine, the red one is aliskiren, and the green line is amlodipine. And the combination we started with always had much better control. You can see you got really good blood pressure control. And then we repeated this with drugs that you're probably more familiar with. This is hydrochlorothiazide and losartan. And we got the same result, that giving the 2 drugs to start with is much better than giving monotherapy. And bizarrely, the combinations all had fewer side effects than monotherapy, which is really bizarre, but that's what we found. One tend to cancel out the other, I suppose. You don't get less angle edema and stuff like that. And the other thing to point out is that we should really, there's good evidence that we shouldn't really wait to get the blood pressure down. I don't know why that did that. We shouldn't really wait till the blood pressure gets down. If you wait 2.7 months, you have increased risks with these patients. So we should get the blood pressure down as quickly as we can, and using 2 drugs to start with is a jolly good idea. Now, that leads us on to what we should be doing in the long term. This is Tony Rogers' study of 4 quarter dose drugs. And 4 quarter dose drugs produces really big falls in blood pressure, which is placebo corrected. So these are polypills, and there's none licensed yet in Britain. But the evidence keeps rising to us be using them. This is another study that appeared just last year about a polypill. But this one had aspirin and simvastatin in it, and I'm not totally convinced about this, but it did produce a significant result in relatively low-risk people. About 80% of them probably had hypertension as well. But I think polypills are coming our way. And the initial law in Wald suggested that even normal people should take the polypill to lower their blood pressure. So Jacob said, who should come to the hypertension clinic? Well, the ones that you run out of guidelines, straightforward. We used to get lots of people, is this patient really hypertensive? And, you know, we do offer ambulatory pressure alone, but most of these now that people have got home blood pressures, it's kind of mostly superseded because most people have got home blood pressures and kind of can, unless you really want a nighttime pressure, home blood pressure monitoring is probably just as good for determining whether there's a white coat effect. Certainly resistant hypertension, that's on 3 drugs and not controlled, or 4 drugs if you want to have added spironolactone already. Young hypertension, because there's a higher incidence of secondary hypertension in those. And people you think have secondary hypertension, you know, people have panic attacks and sweating and all that sort of thing. It might be a FeO, or people who have hypokalemia, it might be aldosteronism. And then the last one is multiple drug intolerance. And there are probably other ones that I haven't thought of, like, you know, multiple comorbidities and lots of perhaps drug interactions, things like that. What do? Everybody in our clinic gets an ABPM before we see them. The nurse sees them in a nurse-led assessment clinic. They all get their blood and their lipids and a whole lot of other things, like they get their urine microalbumin done in the lab so we can rely on it. They have a secondary hypertension screen. We do renin, aldosterone network scores, and other targeted investigations. So we do a pretty good job of trying to screen out the secondary hypertension. So here's a sort of case study. This is a 36-year-old who's terrible blood pressure despite multiple drug therapy. and this is called resistant hypertension, and the clinic pressure is 230 over 130, the ABPM is 210 over 118. Phew! She's got reduced nocturnal dip, and she's supposed to be on lisinopril, doxazosin, amlodipine, bendoflumin, thiazide, moxonidine, and aliskiren. And her urine, when we tried to detect these drugs, didn't contain any of these drugs at all. So this lady was not taking her tablets at all. And drugs don't work in patients who don't take them, said this man, who's former US surgeon, C. Everett Koop. I should point out that drugs don't cause side effects in people that don't take them, although maybe this one does. This is Obalcalp. I don't know if you've ever heard of Obalcalp. It's available in pharmacies in America. And it's actually placebo spelled backwards. And placebo does cause side effects. And you can buy actually a maximum strength Obalcalp as well, but you pay more for it. Maximum strength placebo. People who are compliant with placebo versus non-compliant have less mortality. So compliance in itself is a marker of good health care, good health behavior. So what we're trying to do is get a good evidential basis for measuring urinary metabolites of drugs. And the great and the good have got together to do this British Heart Foundation study. I'm in the bottom corner here, the slightly fat-faced one. I think you can actually get your urine metabolites down in Edinburgh at the moment, but we're trying to prove that it works, that it actually makes a difference. And Matt Chatshire is the chap who's leading this. He's currently the International Society of Hypertension president. So if you've got somebody you think might have non-compliance, let us know, and we'll put them in the outreach study. Resistant hypertension does respond to a low-salt diet, quite big falls in blood pressure. The only reason for pointing this out is that your chairman and ourselves did a study showing that fizzy drugs and soluble drugs contain one hell of a lot of sodium, and that that increases hypertension sevenfold and doubles mortality. So one of the things to look at in your people with resistant hypertension is are they taking fizzy drugs? And maybe don't give them fizzy drugs anymore. So we prescribe quite a lot of unlicensed drugs. Spironolactone has not got a license for hypertension. Neither is Amiloride. Neither is eplerenone. Amiloride does. Tadalafil doesn't, and sacubitril valsartan doesn't, and empagliflozin doesn't, and all the others don't. Yet whenever we prescribe these, because you run out of drugs and we give them these drugs to try and lower their blood pressure, your practice pharmacist won't prescribe them, won't let you prescribe them. Well, what's the point in us trying to lower the blood pressure when nobody will prescribe the drug? So we need to kind of fix that. We don't do it very often, but sometimes, it works very well. This is the evidence for spironolactone, Pathway 2 study. No doubt whatsoever, spironolactone was great. And it's dose-related as well. You need to be careful with this. Start low, go slow. Watch out for a patient with diabetic and low GFR. You give half the smallest tablet every second day, perhaps, if you're worried. There is a liquid available at the pharmacist's here at 5 milligrams and 5 mils. And you need to totalize a little bit of rise in potassium and creatinine because it'll come back down again, then you can increase the dose. Do that, you'll get them on spironolactone. Give them 50 milligrams, they'll be hospitalized with renal failure. So let's be careful about this. If we do it this way, we've shown quite clearly, and Alex Watson was the GP who did it with us, shows that it's safe if you use this adequate monitoring. Eplerenone's it's just not as potent as spironolactone. That's why it doesn't cause so many problems. But it doesn't lower blood pressure as much either. So Spiro's the cat's pajamas. Eplerenone we sometimes use if we want to give a very low dose. This is the evidence for tadalafil, which is, of course, a drug used in erectile impotence. So it's very useful to have a man who's got erectile dysfunction, who's hypertension, and he's resistant to hypertension. Tadalafil is quite a useful drug, but try and give it to somebody who doesn't have erectile dysfunction, and the practice pharmacist whinges. We have to sometimes send them all the evidence. The parameter study showed very clearly that sacubitril valsartan was better than olmesartan on blood pressure reduction. Really very good indeed. And that we use this, but it's not licensed for hypertension. Again, it's a heart failure drug. We sometimes use these older drugs, Methyldopa Clonidine, Phenoxybenzamine, Verapamil, Minoxidil, Amiloride, probably drugs that you've never come across before. Now, I'm not going to talk a lot about secondary hypertension. There's lots of causes. The common ones are on one side and the uncommon on the other. We think there's quite a high incidence of aldosteronism. In fact, this is John Flunder from Australia. He thinks a lot of hypertensive patients have inappropriate secretion of aldosterone. That might be why Spiro is such an effective drug. Polycystic kidneys and renal disease, a very common cause of hypertension. Obstructive sleep apnea. We screen everyone with a Epworth sleepiness score, and we send a lot of people for sleep studies. We don't really do angioplasty and stenting anymore. We just don't do that anymore. The reason is that the Astral trial showed no benefit and substantial risk, and the Coral study showed no benefit. We took part in these studies, and there was no benefit of stenting. So, stenting for renal artery stenosis is a bit of a lemon altogether. We sometimes do it if the renal function is deteriorating rapidly. The one thing that we do is look for fibromuscular dysplasia in young women, because this is curative if we just angioplasty them. Drug intolerance is a problem. Many patients, they often take many drugs. It's difficult to know which one's causing the intolerance. The first approach is to advise them to stop and start a few times. And, you could do an N of 1 crossover study. We did this with statins. This was people who had statin symptoms who we crossed over between statin and placebo and asked them for their symptoms at the end of every month. And guess what? There was no difference in muscle symptoms between statin and placebo. But you could argue that everyone's intolerant should get an N of 1 crossover trial of every drug. Now, I was talking about low doses. This is diuretics, half dose, standard dose, double dose, blood pressure fall, blood pressure fall, blood pressure fall. Not very steep, but side effect fall, side effect fall, side effect rise. Huge increase in side effects with dose. So the best bang for your buck comes with a low dose. And so low dose, best benefit to intolerance ratio, and the recipe for the intolerant is multiple low dose. So sometimes we would combine low dose drugs like every second day, take a half tablet. So, a low dose of benflumethiazide a few days a week and an ARB alternative week. And they're better to take something rather than nothing to lower the blood pressure. Finally, there's devices. Now, we stopped doing renal denervation. We have one patient who had baroreceptor stimulation where they get their baroreceptor stimulated, but it does work, but it's not going to be to help everyone. So that's me. I've just taken 40 minutes, I think, Jacob. I didn't put in everything in this talk because you could talk for hours and hours and hours about management of hypertension. Our academic currency is to keep calm and publish papers, and that's what we aim to do. So thank you for listening.
Thank you, Tom, for that excellent lecture on the management of hypertension, and lots of useful information in there. So Shirley, if you can unmute the participants, and please feel free to raise your hands or type in any questions if you've got them. Right, we've already got people raising their hands. So we've got Sheena. Sheena, please do come in and unmute yourself. If you can, turn your camera on and ask your question.
No, Sheena.
We need you to unmute yourself. Shirley, are you able to unmute everyone?
Oh, there's Sheena. That's Sheena. Sheena turns out to be a man.
That's Donald there.
If everyone should be unmuted now and allowing cameras. I think the one guest is showing that. Okay,
Sheena, please, can you unmute yourself and do come in, please, with your question?
No, lots of people.
Yep. I think she's unmuted herself. Please do come in with your question. Thanks. Hello, Sheena. While we wait for Sheena's question, are there any others who would like to?
My hand is up.
Okay, I've got here, Tom, I've got Michelle Bartlett asking, patients with low blood pressure who are not dizzy, is there any point that low blood pressure is a risk for renal function?
Yes.
Possibly. I think it depends what you mean by low blood pressure. And I'm not yet convinced that I know what really low blood pressure is if you have no symptoms. I mean, John Clelland's sitting there and he's probably seen lots of patients with a systolic of 80 who are completely asymptomatic with heart failure. But Possibly, I suppose. I mean,
so Michelle clarified that, Tom, with a blood pressure of 90/60. Is there any risk of renal dysfunction with very low blood pressure as a question?
Well, I'm not a renal physician, but I wouldn't stop their treatment if they're asymptomatic.
Just measure creatinine.
Pardon?
Just measure their creatinine.
Well, that's the easy thing to do, yes.
Yep. So just, the blood pressure is low, measure the creatinine. If the creatinine has gone up 100 points, then maybe you should back off on the medication. That's how we would do it in the heart failure clinic.
Thank you, John, for coming in there. There's another question from Sasha Trani, who says, frailty consultants like to give a relaxed target of even 160/90 millimeters mercury for older, more frail patients. Any comments?
So they did an analysis of frailty in the SPRINT study, and they didn't find any major adverse outcomes in frail patients. So I think they were rather surprised by that, but frailty didn't seem to cause bad outcomes when they were trying to lower the blood pressure. And I think the more you do research in this area, the more it surprises you. And I think the very patients we haven't been lowering the blood pressure are the ones who need it most. And I don't think that frailty is, I mean, maybe you'd be a bit more careful with a frail patient, but frailty in the SPRINT trial was actually, it's published, and it wasn't such a bad, it didn't have really bad outcomes.
But Tom, the studies that you're doing, the cluster randomized trials, are surely the ones that are really going to answer this question, because I think that when you do an individual patient randomized trial and you have 10 individual patients, you effectively exclude your frailest patient. But your cluster randomized approach should really deal with it.
It's a good point, John. What we really need in the NHS is studies which have what's called good external validity. And those are studies that take place in the setting of the NHS, and individual patients signing up for trials are fit, healthy people who want to take part in research, and that's the problem. So Donald Gamble's got his hand on his face there, thinking, looking at me in a way. Donald, did you have a question?
Yeah,
Donald,
one
please.
thing I was wondering about, I'm mostly retired now, but I still work in an out-of-hours GP, and I get up a lot of patients who, some on treatment, some on not, phoning in with very high blood pressure. And which ones, particularly asymptomatic, which ones do we worry about?
High blood pressure I always worry about.
You know, something like 230, 240.
All right, so who should you send in? I think the question is, who should you send, who should you treat now, and who should you send in the hospital?
We don't have any treatment as such, you know.
No. Well, the answer to that you might not like is to look in their eyes and see if they've got hemorrhages or anything like that. And if they have got hemorrhages, they've got accelerated phase hypertension. And if they don't, then they don't, and you can treat them. And I think that's not an easy answer for general practice, because it's quite hard to look in eyes. And even if you dilate them up, it's still quite hard to look in eyes. And I think that is a difficult area. But if you wanted to differentiate accelerated phase hypertension from high blood pressure, which is safe to treat, probably you need to look in the eyes, and it's you maybe need to have some drops with you.
Proteinuria help you at all?
It could do. If they had gross proteinuria, but even that necessarily. Heart failure is perhaps if they've got, you know, that's probably accelerated phase hypertension. But most of these people who are sitting there normal without these things, you need to look in the eyes. Sorry.
Okay.
Thanks, Tom. I'm just looking for any other questions in the chat or anyone else.
Here
Can I ask you about Moxonidine? Do you ever use that?
Pardon?
Moxonidine, the only study I know with Moxonidine, the patients had a bad outcome. It did worse.
We use every sort of drug we can in Clonidine, Moxonidine. We use a lot of these usually in people who've got other indications for it, like you know, Clonidine patches are quite useful, but you can't actually get them easily. You have to import them to get. We've got one patient on Clonidine patches who does quite well with it, but I think part of the problem we face is that when you start prescribing unusual drugs, you just get lots of feedback from the primary care people saying, why are you giving this drug? It's not indicated. And that's an issue, I think.
Tom, we see a lot of young people with isolated diastolic hypertension, with fairly normal or even low systolics. Do you want to comment on what we should do with them?
So I think there's no doubt that systolic hypertension is more important, but diastolic hypertension isn't to be ignored, especially in young people. And the risks are not as much as with systolic hypertension, but are definitely there. And so diastolic hypertension should be managed, and in the same way as systolic hypertension is managed.
Thank you, Tom. Any other questions at all for Prof. Macdonald? See no further hands. I'd just like to thank, I see Mary Galbraith has come. Are there any studies that look at long-term blood pressure monitoring of patients who have had hypertensive disorders in pregnancy?
Well, hypertension in pregnancy is interesting. I mean, first of all, there's a patient who's hypertensive who's going to become pregnant, which is quite interesting. Hypertension in pregnancy tends to predict those who will become pregnant, who will become hypertensive in the future. Unfortunately, it's one of the risk factors for it. And that's not necessarily, that's pregnancy-associated hypertension, not necessarily preeclampsia. So it's a whole subject in itself. I'm not a great expert on pregnancy and preeclampsia, but we see a lot of patients who are pregnant with hypertension, and managing them, they get a bucket load of old drugs because we don't know what the new drugs do. So they get a bucket load of old drugs like Methyldopa, and at least they only have to take it for 9 months.
Thank you, Tom. Claire Cadogan asks you, interesting to hear about combination medicines being quite effective. If I've started a patient on a second drug and up-titrated, and it's not made much difference to the blood pressure, patients are generally not keen to add in a third line, and just ask if I can try an alternative second line as they don't want multiple medications.
Yeah, well, there's drugs which are said to be synergistic, and there are drugs which are said not to be synergistic. The evidential basis for that is kind of hard to tease out, but we think that drugs which block the renin-angiotensin system combined with drugs which stimulate it are a reasonably good combination, whereas drugs which both block it, not really such good, and drugs which both stimulate it are not such good. What we really want is lots more combination treatments, and like in one tablet, because what the patient wants is one single pill to take. And it would be very nice to have polypills. My utopia would be a big grid of different combinations of drugs that we could pick, and you could move from the green one to the blue one to the yellow one to the purple one and they all have different combinations within them. And the trouble is not that we can't do that. The trouble is the licensing of these drugs, because the licensing people want to know that the combination is identical to the individual components, and that's very expensive to do. So there's been large outcome trials of polypills to try and get licenses for these tablets. But sometimes they're trying to get a license for cardiovascular risk. I don't know if you remember a drug called Caduate, which was amlodipine and atorvastatin. We couldn't get licensed in this country because they didn't regard cardiovascular risk as a disease. This is very bizarre. But it's licensed in America. Now, I think lots of drugs have been used in polypill combinations in India and around the world. We're probably going to use one in a trial to reduce dementia, because blood pressure reduction probably also reduces dementia. I think we should be leaning now on the MHRA to license polypills so that we can use them. And I think now that we're out of Europe, we might be able to do that. Maybe Jacob could do that. You could write that down, Jacob. One of the things we need to do is you're working with the MHRA in the future.
Thank you. Any other questions at all for Tom? If not, I'd just like to thank you, Tom, once again for an excellent lecture, very entertaining, and also lots of useful information. And thank you all for attending. We will try and email you your certificates in the coming days so that you've got evidence of attending this. And
Can I get one? Can I get one?
Yes, of course you can. Can I also just encourage you to join Sharp if you haven't? It's a great society, and like I said before at the start, we've waived the membership fee. So please do join us and take advantage of what's on offer. We will have about 3 or 4 of these webinars in the coming months on different topics, as I said at the beginning. So thank you very much. If you want details about Sharp, you can just Google Sharp Scotland, and that should take you to the Sharp website, and you can click on Join Sharp. So that's probably the easiest thing to say. Okay, thanks very much, everyone, and
Bye now.
good night. Good night.
Bye.